Hello dear viewers, this is CRRT part 2. In part 1 of CRRT, I discussed an overview of this therapy. In this video, I am going to discuss various terminologies used during application of CRRT in intensive care unit. Let us understand these terminologies to make informed choices regarding this therapy in critically ill patients. I am Dr. Sunil Garg from Essentials of Acute Care. First, we will discuss two commonly used principles of solute clearance in CRRT, and that is diffusion and convection. Diffusion is the movement of solute across a semi-permeable membrane from an area of higher concentration to an area of lower concentration driven by concentration gradient. Solutes naturally move from where they are more concentrated to where they are less concentrated until equilibrium is reached. Diffusion is effective at removing small molecules like urea and creatinine from the blood. Diffusion's effectiveness decreases as solute molecular weight increases. Since movement of solute occurs across semipermeable membrane from high solute concentration to low solute concentration, dialysate fluid is required. Small molecular weight solutes are easily removed by diffusion. The higher the concentration gradient, the higher the diffusion rate. To maintain a high diffusion rate or high diffusion gradient, the difference between the blood and the dialysate concentration must be maintained, and this can be done either by increasing dialysate or the blood flow rate. Increasing the dialysate rate maintains a low concentration of solute on the dialysate side, while increasing the blood flow rate brings more solute to the filter, promoting continuous diffusion. Convection, on the other hand, is a bulk flow of solute across the membrane driven by hydrostatic pressure through movement of fluid, which is also known as hemofiltration. Hemofiltration means removal of water from the blood, which creates a convective current that drags solute across the membrane. It is particularly useful for removing larger molecules like cytokines and other inflammatory mediators. For this modality, no dialysate fluid is required as there is no diffusion. Dialysate. Dialysate is fluid which is passed through hemofilter designed to remove waste products from the blood by diffusion. It is passed in the counter current direction to blood flow. The concentration of solutes in the dialysate fluid determines the diffusion gradient, hence solute clearance. In CRRT, dialysate fluids are sterile. In renal replacement therapy, ultrafiltration is the process of removing excess water across a semi-permeable membrane driven by a pressure gradient. This is similar to how the kidney naturally filters fluid from the blood and makes urine. This process is used to manage fluid overload in patients with acute kidney injury or other conditions where the kidney cannot perform this function adequately. So, aim is to create negative fluid balance. Hemofiltration. It is removal of relatively large volume of fluid by ultrafiltration, resulting in removal of solutes through convection. So, aim is to clear the solute through convection. Replacement fluid is given to replenish lost volume. Replacement fluid. Pulling large volume of water across the semi-permeable membrane creates a convective current that drags additional solutes. While diffusion is effective at removing most small molecules, convection enhances the removal of small and mid-sized molecules Thus, convection can be added to enhance solute removal. To prevent hypovolemia, any water removed during hemofiltration must be returned to the blood before it reaches to the patient, and this is called replacement fluid. Any fluid removed during hemofiltration is given back to maintain a net neutral fluid balance. Replacement fluid must be sterile intravenous fluids with concentration of electrolytes similar to plasma. Replacement fluids can be returned either pre or post filter. This is referred to as pre-dilution or post-dilution. Pre-dilution means that the replacement solution is returned to the blood before it reaches the filter, diluting the blood in the hollow fibers. And post-dilution means that the replacement fluid is returned to the blood after the filter but before the return side of the access catheter. Pre-dilution dilutes the blood in the filter, reducing the clotting, while post-dilution concentrates the blood in the filter, enhancing clearance. Effluent. It refers to the combined fluid removal from a patient's blood during the process, including both dialysate and ultrafiltrate. It essentially represents the liquid waste produced by the CRRT machine as it filters and cleans the blood. Semipermeable membrane, a membrane with pores that allow water and small molecules to pass through but do not allow larger molecules like blood cells and proteins to pass through membrane. Membranes need to be efficient at clearing waste and biocompatible with human blood means exposure of blood to the dialysis membrane produces minimal adverse effects. Permeability of membrane is influenced by the pore size, number of pores and the thickness of membrane. Solutes pass through the membrane according to solute size. High flux membrane that have a larger pore size increases the rate of clearance by allowing larger molecules to pass through the membrane and by allowing more ultrafiltrate flow. Permeability of solute decreases as the molecular size increases. The surface area of the membrane determines the available area for diffusion and ultrafiltration. Filtration fraction. It is a percentage of plasma that is being removed from the blood during hemofiltration. It tells us likelihood of filter clotting. The optimal filtration fraction during CRRT is not known. Successful dialysis without anticoagulation with a filtration fraction of 15 to 20% is possible. Filtration fraction higher than 20 to 25% increases the risk of filter clotting. Higher transmembrane pressure will increase the filtration fraction and increase in the oncotic pressure will decrease filtration fraction. Excess pressure. It is negative pressure required to draw blood from the patient into the dialysis circuit. It is typically measured between the catheter and the blood pump. Normal excess pressure range from -50 to -200 mm of mercury. Excess pressure within range ensures that blood is effectively aspirated from the patient into the CRRT machine. It can indicate the functionality of the vascular access and may drop during patient movements or coughing. Return pressure is the positive pressure used to re-infuse blood back into the patient after it has been filtered. It indicates the effectiveness of the return line and the overall circuit. It is measured between the filter and the patient on the return line. Normal range of return pressure typically range from +50 to plus 200 mm of mercury. Monitoring return pressure helps identify potential issues like kinks or blockage, as a high return pressure could indicate a kink in the return line or blockage in the catheter. A sudden drop in return pressure could signal a disconnection of the return line. Higher blood flow typically leads to higher return pressure. Transmembrane pressure or TMP is hydrostatic pressure gradient across the dialysis membrane, reflecting the forces driving fluid and solute movement. It will rise gradually at stable blood flow and effluent rate throughout the life of the filter, beginning to rise when the filter becomes plugged with clot or protein buildup. A clot in the circuit will cause the TMP to rise. A high TMP with normal return pressure indicates that filter problem, means clotting or the accumulation of protein on the membrane surface. TMP will increase with any increase in the blood flow. The TMP plus the rate of TMP rise contributes to filter clotting alarm. A TMP above 350 mm of mercury will produce an advisory alarm. Filter pressure drop is another indicator of clotting. It is the difference between filter and return pressure. Filter pressure is the pressure of blood as it enters the filter, and return pressure is the pressure of blood as it exits the filter and return to the patient. Essentially, pressure drop is drop in pressure across hemofilter. It will slowly rise during normal treatment. Here I finish. Thanks for watching this video. I hope I was able to explain it. Still, if you have any suggestions or feedback, please write them down in the comment section. See you with my next video in CRRT part 3. Till then, bye and take care.